Ladies and gentlemen, please welcome Steve Christian, Director of Strategic Accounts and Operations for Abbott Laboratories.
Thank you and good afternoon. I am Steve Christian with Abbott, and I have the distinct privilege of serving as the chairman of the Medical Surgical Subcommittee for the last year. I want to formally welcome you to today's Supply Chain Workshop Forum. Just a couple of housekeeping items to get through. We've not scheduled any breaks during the session, so please feel free to avail yourself of any of the beverages that have been provided. If you've attended this workshop previously, you know that our subcommittee strongly encourages your feedback and places a high degree of value on your personal evaluations and recommendations. In fact, this session is a half an hour shorter this year than last because of your evaluations and the comments you brought back to us, so thank you. Your comments will help us structure improvements in next year's workshop, so please reply to the evaluation survey when you receive this via email following today's discussion. As in past years, we will randomly select one submitted evaluation to receive a Marriott gift card. So please, again, complete your evaluation so you may be eligible for that gift. Today's workshop is entitled 2018 Not Your Mother's Healthcare, and as last year includes panelists who are leaders in their respective clinical and health systems. We're also very fortunate to have John Pritchard returning as our moderator, who's been working diligently with our subcommittee in preparing for today's event. You've likely noticed that there were blank index cards at each of your tables when you entered the room today. That index card represents your opportunity to submit questions to our moderator, who could then share your question with our panelists. You will see several of our subcommittee members collecting those cards throughout the workshop today. One last thing before I introduce our moderator, I would be remiss if I did not take a second to recognize all of those who have served on the Medical Surgical Subcommittee this past year. If you were a member of our 2017 subcommittee, would you please stand so that we may all applaud your efforts building up to today's event. Now I would like to turn the microphone over to our moderator, John Pritchard. John is the president of Share Moving Media and has been a dynamic leader in our industry for over 30 years as president of Share Moving Media, publisher, the Journal of Healthcare Contracting, as well as the National Accounts Weekly. I present to you Mr. John Pritchard.
Thank you. Thank you, Steve, and thank you for your leadership on the committee. I would say hello to everybody. Welcome to today's Supply Chain Forum. I'm excited to be here. It's been fun to watch this forum morph over the years from a GPO-only panel in times where we thought there maybe we even hoped for a fist fight, to these more elegant times when we'll have a lively discussion and have brought in an IDN panel as well. So it's great to be back here. All of the members of the panel today have an extensive bio in the app. So if you would like to look them up and read a little bit more about them, you can there. Today I'll just introduce them by name, title, and organization, and then I'll let them each give us a quick snippet of what their responsibilities are. And I'll just go in order of how we're seated on the stage here. Melinda Gardner, Senior Vice President, Enterprise Information and Data Management from Vizient. Welcome, Melinda. Thank you for being here. David Hargraves, Senior Vice President, Supply Chain with Premier. Todd Larkin, Senior Vice President, Contracting with Intelir. Welcome. Thank you for being here. David Osborne, Senior Vice President, Advisory Solutions with Health Trust. And our IDN panelist, Dr. Nita Mukha, Physician Advisor, Supply Chain, Virginia Mason Medical Center. Welcome, thank you. Dr. Randy Moore, President, Mercy Virtual. Welcome and thank you. And Simrit Sandhu, Executive Director, the Cleveland Clinic, and also the front cover of the December issue of the Journal of Healthcare Contracting. So welcome all of you. Thank you for being here. And Melinda, I'd like to start with you, and if we could just kind of go in the same order, give us a little bit of what your responsibilities are, please.
Okay, sure. As you mentioned, I lead the Enterprise Information and Data Management area at Vizient. My area is very focused on providing data operations in support of our own internal business needs like sourcing, but also for a lot of the products and services we provide to members. So busy bringing in all of the hospital data, whether it's the supply, clinical, or operational data we use to support our analytic products and our advisory services. Also doing a lot in the supply chain area around standards, building out our product master, managing our price data, as well as our membership data, and then a little bit of supply analytics on the side. So excited to be here today.
Thank you. David?
Hi, David Hargraves with Premier, so SVP Supply Chain Services. Supply Chain Services for us is the group purchasing organization, and let me take a minute to thank you, all the suppliers. It's been great being with you all here these last few days and working on our mutual customers. It's also our e-commerce platform and also our S2S Global, which is our self-manufactured products, and then any of the performance groups that you may be benefited to have a contract in. So if it's something supply chain, then it's an area that I work in Premier. So thank you for having me.
Todd, please.
Yeah, thank you, and good afternoon. Todd Larkin, Senior Vice President for Contracting at Intelair. I joined Intelair in August of last year, so relatively new to the company. Relatively new to the GPO space, but learning a lot every day. And I want to, as David also mentioned, I want to thank each of you. It's been great to connect with you over the course of the week and really start to develop relationships. So I appreciate your involvement here this afternoon. My responsibility, my team is focused on sourcing and contracting for Intelair and its membership, as well as spend analysis, contract operational support, and we also are building out a number of capabilities in our program management area where we have traditional GPO models, but also building out clinical programs as well as programs focused on typical business solutions or business challenges that our members face, from cybersecurity to sustainability to supply chain resiliency, et cetera. So, thank you.
Thank you, Todd. David?
So David Osborne with Health Trust, thanks for being here and delighted to be on this panel. I've got leadership responsibility at Health Trust for advisory services across our three buckets, if you will, of work in supply chain, in clinical performance and integration, and in workforce and labor and productivity. In that role, we work with mostly Health Trust members, but some other parties as well, other health systems around the country, trying to achieve enhancements to performance beyond what we do and in addition to what we do on the GPO side around pricing and savings there. We kind of bring people to help with assess, develop recommendations, implement, in some cases provide leadership for some period of time in those three areas. And we bring our people, we bring intellectual property, and we bring kind of the data and analytics tools that we need. And that's what I spend my time. So again, glad to be here with you.
Great, thank you.
So I'm Nita Mukha. I work at Virginia Mason Medical Center. Just like my title says, I am the physician advisor and embedded in the supply chain. So I work very closely with our supply chain in collaboration with our physicians, primarily our surgeons on GPO compliance and implant standardization and standardization in a lot of other areas as well. In addition, I'm a shared resource with our group purchasing organization, which we own, Health Resource Services, which is a very strong and supportive marketing affiliate of Intelair. So I serve in an advisory capacity for them as well.
Great, thank you, welcome. Randy?
Hey, Randy Moore. I'm kind of the odd guy out. So my job is to lead the Mercy Virtual Organization. We're about 800 FTEs, growing very rapidly. And I'm going to bring up the A word. We're kind of some ways like the Amazon of what might happen. A very simple challenge I'll give us to think about, which is what happens if instead of asking the patient to come to care, which can be very complex, we bring care to the patient. Not just what we do today, but in a radically different way, learn about them, reinvent the model of care. And what we're seeing, we talk more as we go, is that we can reduce the utilization of healthcare resources by about 50% in the hospital and outside the hospital while we significantly improve the outcome of the patient. And that's the value equation people are looking for. So I'm the best friend of all our hospital presidents when I come and say, you've got to pay me to get rid of 50% of your admissions.
Thank you. Cymryd?
That makes you more popular than me, trying to reduce and eliminate choice with physicians. So having said that, I am Cymryd Sandhu. I head up supply chain operations for the Cleveland Clinic. Most of you are familiar with the clinic. Most of our hospitals are in Northeast Ohio. We're growing in the Florida market. We have a facility in Vegas and soon to open a hospital in the UK. So we plan entering the UK market in 2020. My span of operations primarily includes all procurement and sourcing activities, materials management, warehousing, including pharmacy. And we recently launched a supply chain services company in partnership with Vizient. The data and analytics products that Melinda referenced really help us create a product in the marketplace called Accelerate that engages physicians in reducing product variation and creating supply care paths across the nation. So we have numerous hospitals across the country that collaborate with the Cleveland Clinic in creating a formulary. What that leads to is more of a limited choice implant contract portfolio that engages physicians in contract compliance. So we'll talk more about that.
Great, thank you. Welcome, everybody. I am thrilled to have a distinguished panel up here. I think the GPOs that we have represented are probably close to a couple $100 billion in contracted throughput. And it's great to have a couple of physicians, real-life clinicians on the panel as well. It was probably about 15 years ago, I was at an industry event, and the topic was healthcare reform. And somebody stopped the discussion and said, could you raise your hand if you actually work for a provider? And there was one provider in the whole room, and that supply chain leader was actually wearing a GPO's shirt. So it was kind of interesting to be working on reform without clinicians or caregivers. And so I think this will be a great discussion. Steve covered our theme today, consumer-focused supply chain, not your mother's healthcare. And I just kind of want to take you through our objectives. So as I ask questions, you can keep those in mind. We want to discuss new factors impacting healthcare supply chain now and in the future. In the past, this discussion has been more sort of what we've already done, what we measure from the past, and so it's a little bit more forward-looking this year. And we also want to know the challenges these changes create, and then the potential impact of new entrants into the supply chain and what you're seeing there. Discuss the resource implications, how things will change on how you allocate resources. And then we want to end with some action items for our audience, keeping in mind we've got a large number of suppliers in the audience, so we can give them good advice to take home. And we're going to do that in 4 parts. One's going to be how will GPOs and IDNs, and then how you guys will respond to these different things, but then also what you would recommend the suppliers do as a result of these changes, and then also talk about the resource implications, the actual items, and then we'll have a Q&A time that Steve mentioned too. So please be ready to prepare your questions, and they'll run them up here, and we'll make sure to get them asked. So moving on to the first one on how GPOs, IDNs, and suppliers respond to these dynamic times. It's hard to even pick up the paper and not see a major merger or acquisition change. And many of these changes are creating odd bedfellows, be it CVS and Aetna, to more traditional M&A with Ascension and Presence. Bon Secours Mercy from Cincinnati last week announced, Aurora and Advocate. The list goes on. And then also you get these great big announcements with the big elephant in the room, Amazon joining forces with Berkshire Hathaway and JP Morgan. It's creating an era of great change and certainly urgency of change. So I'm going to start with you, David Hargraves, if I could. We all know things are changing drastically. If you would, look into your crystal ball for us. Tell me what you see. What does the supply chain of the future look like, and when will we see that?
Thank you, and thanks for letting me go first. I appreciate the warm-up. When we've done this panel in other years, we're able to hide notes in front of us and take people down. No ability today, so with it. But it's really important. So the level of mergers and acquisitions you see now has never been, it's unprecedented. It's never been higher than it is right now. So there's a couple of things that are obvious that'll come, but if I can answer your question, let's go a layer or 2 deeper. So the first one, you'll have fewer providers, right? Fewer customers that you'll have. They'll all be bigger, and when they're bigger, They become more sophisticated, not just by sheer size, but because you have to. So I'll pause there just for a second. If you go back just 10 years or 12 years ago, a supply chain department could be literally a dozen or two people in a single facility. Then you had the IDNs, and now maybe you got to a couple hundred employees, and now it's not uncommon in some of these mega IDNs that you've got 1,000, 2,000 supply chain employees that are doing this. So one is the size of the organization. But along the same way, their role has changed from going from being in charge of supplies only to now being in charge of all non-labor expenses. So when you get one of these institutions with 1,000 plus supply chain people, they also went from being in charge of a couple $100 of cost, a couple $100 million, to $2 billion, $3 billion in cost. And so the degree of sophistication that come along is because of that trend. The guy that you had a decade ago and the guy or gal that you need today to run that are two very different people. The other thing that changes when you change with that scale, though, is every bit of work that you did. So take an example, even things as common as invoicing, okay? When I left UPMC, my prior employee, when I left there, we were 72,000 invoices a month that would come in. And every one of those you wanted to pay on time for your suppliers, but you also wanted to pay accurately. So when you get to that scale, a purchase order issued every 24 seconds, 72,000 invoices a month, it requires a large suite of technology tools. It's simply not possible, even with thousands of employees, to be able to handle that sort of volume. So the next thing that comes in, aside from bigger and smarter and more sophisticated, is that technology is no longer nice to have, it's an absolute requirement. So automation of all your tasks. And when you get to that, when you go to automate the tasks, now to make your life easier and sustainable, now you move towards a standardization, right? With the variation you can have in one facility, when you get to 30 hospitals and 50 hospitals and they're spread across multiple states, you simply can't handle it the same way. So all of the core things that we do stay the same, right? But the value that they bring, it scales up tremendously. So now I look to the future, because all that's happening today. Well, what will happen if we want to say what's going to happen in our industry? Let's look to other industries where you've had mass consolidation in any of the industries, consumer electronics, automotive, metals and mining, it doesn't matter. When you get the mass consolidation and you get the very large supply chain departments, what often happens is you actually bring in other folks to help you. So it's an interesting impact, I think, John, it'll have on the GPO world. If you are some of the large consumer brands that you think of, they often then make a decision at some point in time. They look back and go, how did I get 3,000 employees in my supply chain? That's not what I'm good at. I'm good at making Coke, or I'm good at making this consumer good. So then they'll turn to service providers and say, hey, why don't you manage this area of my supply chain for me, third-party logistics, or maybe they outsource their non-direct materials to an Accenture or an IBM or some BPO company. So a question that we'll all be faced with is, when do you get so large that it actually makes sense for you not to own some of those services and you bring in a service provider? And the interesting twist in ours, which again exists in all their industry, is, and when does the suppliers today go from being a product supplier to then taking over those areas of expertise? You have a couple examples, I won't name names, but a few suppliers in the audience now have now taken over clinical areas and outsourcing in that. So as we get fewer, bigger, smarter customers, I think you'll also see in it a resurgence of some of the business process outsourcing and some changes in ownership as well.
Thank you, David. Cymryd, I'd pose the same question to you from an IDN's perspective, if you could certainly speak on behalf of your experience, but what's in your crystal ball? What does the supply chain of the future look like, and when will we see it?
Sure. So one of the I'll piggyback off the comments that were made. They were right on target. The interesting thing is you get to a discernment of core competence or not once you've stabilized. The comments being made are, when you're a stable industry and you've standardized, you start questioning what's core, what's not core. At the clinic, for example, we were one of the first hospitals to build a CSC. Once we stabilized, a consolidated service center, self-distribution. Once we stabilized, we realized all our costs were in the ORs and the procedural areas. They didn't lie in the warehouses. We had invested tremendous dollars in building these CSCs, and my costs were in the ORs and procedural areas. Today, we're automating through RFID tagging the WaveMark SIMS product, our entire OR and procedural area suite. Why do I focus in on that? My crystal ball says that to be the industry of the future, I have to demand plan. I have to manage a supply base from a demand planning perspective. My demand is the patient. If I do not take my supply chain and tie it to case scheduling and patients, I will never be able to piggyback off models like Amazon, models like third-party outsourced service providers. So as a provider, my crystal ball says, I have to manage what I manage best, my demand. I have to start predicting my demand. When do my patients come? What procedures are scheduled? What products do they need? Do I have a formulary? Things that a provider should manage should be managed by a supply chain internally. So I don't ever see myself outsourcing that. If anything, those are the hard things that people like me have to start doing and providing that data then back to the suppliers, back to the GPOs, back to the distributors, or to an Amazon, to be controversial, to start seeing if things that other industries have done, things that car manufacturing or retail have done for years, can be done in healthcare or not.
Interesting, Cymryd. I've done a lot of work with you editorially and also on calls, and it's amazing to see Cleveland Clinic from arm's length. Seems like a very stoic institution, conservative in nature, but part and parcel to everything you do and some of these progressive supply chain trends is having change management all through your organization. I know that's a passion of yours. Could you touch on that a little bit? Why is change management so important in this time of great change?
Well, we have to be very, very effective stewards of our cost. I mean, care affordability is what this is about. We talk a lot about cost reduction and supply chain, and I was talking, I think Nita made a very interesting comment about that. I tend not to talk about cost reductions or cost savings. I talk about care affordability. Hopefully, we're doing all these things to make care more affordable for our patients. And for the Cleveland Clinic, at least our culture talks about make people work to the top of their licensure. What we have discovered over the years is that a lot of the supply chain work in hospitals is being done by nurses and doctors. Yes, we run warehouses, and there are runners that run product from warehouses to the floors. But who truly is managing a lot of the ordering, the replenishment in the ORs? Who's trying to look at the pick lists and the preference cards? Where does all that hard work happen? And you find that a lot of this work is being done by our nurses. And with that aha moment comes this realization of to create a better supply chain, you have to change the workflow of a hospital. A supply chain alone can't make that happen. And the concept of engaging stakeholders into a supply chain is probably what differentiates us. To us, a supply chain is an end-to-end connection of the ecosystem. And from the patient back to the physician, back to the nurse, back to the supply worker, back to the core storeroom, back to that major storeroom, back to the distributor, to the GPO, is a continuous connection point. And we've lost track of that. Without effective change management that goes through this ecosystem, we can't even hope to look at that crystal ball, in my opinion.
Great, thank you for your insight. And David Osborne from Health Trust, I'm going to ask you to comment on the same thing, and particularly your side with advisory services. What do you see different? What's going to change in this supply chain, and when will we see it? What will it look like?
Sure, John. I could go a lot of different directions with this, but to maybe piggyback on something David said, if the customers and the health systems are going to get larger, they're going to get smarter, they're going to get more sophisticated, they've got more access to vast amounts of information from lots of sources, somewhere in there becomes the need to deliver on the promise of the synergies that the consolidation was supposed to deliver, and some board is theoretically looking over that somewhere to see if 18 months later you've done that. So speed's a real big deal. It's not just size, not just sophistication. We're all going to have to be much more agile. We're going to have to be able to move much faster. The suppliers are going to have to be able to answer questions faster, show evidence faster, engage with different characters, and it's not the same person I was talking to 2 months ago. I got to orient myself to a whole new senior leadership team, and I got 3 months to create relationships and go through contracted cycle times, if you will, for business. So that's got implications for us on the GPO side, the health system side, the supplier side. We're going to have to be agile, we're going to have to fast, and we're going to have to figure out new ways to do the things that just aren't going to produce the results. The other thing I'd say, John, is, and this is not particularly new or sexy, but it's something that I think we got to get better at and we got to do more of, and that is how we really clinically integrate our supply chain, align the clinical leadership, the supply chain leadership in meaningful ways. If you listen to the secretary yesterday, if you read anything that's written There's no doubt that the need for more value is going to go up, not down. The need to produce that value is going to speed up. So we got to find huge chunks of cost that we can take out. We got to find ways to improve outcomes and patient experience. And we can't do that if our supply chain leadership and our clinical leadership and practitioners aren't figuring out ways to work more together, aren't learning about each other's world more. That's a huge area of focus for us, is how do we help clinicians learn the business side of things? How do we help the business side of folks understand what's important to an orthopedic surgeon around this particular device, which costs $300 more, but takes 8 minutes less in the surgery, so I get an extra case a day. There's not a lot of that conversation that takes place on its own. The suppliers can help us in that in terms of resources and education that can be given to multiple stakeholder groups, not just one or the other, but we got to get better at delivering on the notion of a truly clinically integrated supply chain.
Great, thank you. Amazon is top of mind for many, certainly for suppliers and distributors. Excuse me, we live in an era of swipe, swipe, click to get something delivered. I think of the nurse that is sitting at home after their shift and orders something from Amazon that's going to be delivered the next day, and then shows up at work the next day and has to go through a requisition process, a requirement approval, and put into a 30-year-old MMIS machine to get replenished, or system to get replenished. I guess the question is, Melinda, and I'm going to steer it to you, what will be the unintended effects of these new entrants? Will GPOs and traditional distributors have to increase data visibility? Will IDNs have to change their ordering patterns and protocols?
Well, I think they're definitely going to have an impact. I think they're already having an impact. If you look at some of the things already said related to the time and pace of change, as consumers are driving our cost or looking at using and paying for our healthcare bills, that consumer aspect that comes into healthcare has already been influenced by things like Amazon, Google, the ease of use, the ability to access information readily, to own information and have real-time control of things is something that's already impacting the healthcare space. As hospitals see the shift in patient care going to that outpatient arena. So yes, we're going to have to adjust. The pace of change is one thing. I think the other big thing that's going to impact us by some of these more technology type entrants is the whole data side of things. If we don't get our data in order, so to speak, then we're not going to be able to keep up with those, and someone else is going to do it for us. We have to have good clarity of who the patients are, of course. We have to have good clarity of what products are being used, so that we can look at our inventory management, we can look at our traditional supply chain kind of movement of products through the system, but also looking at data from the clinical perspective and how do we start linking some of that supply data, patient data together to have meaningful outcomes. All of those changes, the pace, the need for the data are going to be, I think, impacted more drastically by some of these outside healthcare entrants than we've seen in the past into our supply chain changes.
Great, thank you. Randy Moore, I'd like to ask you the same question. If we can have virtual care, can we have virtual suppliers? And what will that do to the current stakeholders, do you think, as far as how, the visibility and the data that they provide?
Sure. So just listening to and building on what people are saying too, I raise a question in terms of getting bigger, being stable, some things we're talking about, and how we need more data and integration, et cetera. Are we potentially asking the wrong question? Because what happens if we wake up and find out through a disruptive approach that 50% of our care went away, and that not the outcome of a given case, but the health of a population improved significantly? And we're at that stage where the technology and the solutions in that work. And I'll give you a story of one program we've done. We've got a wide range of programs taking care of everything from healthy entrants to the sick of the sick. But talk about the sickest of the sick, and what I want to move this towards is to be thinking about how you get to the consumer on a real-time proactive basis in their daily life, because that's where I think a lot of care is going to go. We took 10 of our patients from our best performing community that was getting nice checks from the insurance companies for Medicare Advantage because we were doing such a good job of keeping these people out of the hospital, out of the emergency room. So we took our best performing community and said, send us 10 patients that we don't care what their diagnoses are or anything, they're just failing, the system can't meet their needs. These 10 patients who ranged in age from like 23 to 87 had between them, listen, 164 hospitalizations in the preceding 2 years. That's in our best performing community. 16.4 hospitalizations per patient over the 2 years. So they're pretty sick. We asked the question, so what happens if we did what we do in the hospital? And that's the key. Hospitalization, what we've learned in hospitals how to build expert interdisciplinary team care and putting the consumer at the center. But I would challenge us to think that's the only time in healthcare we put the consumer at the center. Why? Because we want to get them in and out efficiently and get them turned around really quickly, right? So we took the same concept home with these people. And in 90 days, we reduced their utilization 72%. Every one of those was a bad hospitalization that didn't happen. Now you think about what we want for each other too. You know, we can sit on two sides. On the one hand, we're suppliers, we're providers, everything in healthcare. We're also all going to be patients. We've been already. So coming back is, I think we need to be challenging ourselves right now. You need to be challenging yourself to say, how do we move to consumer centricity? Not just provider-centric, system-centric, but consumer centricity. We can learn it in the hospital and do it really well, but we should be thinking in a parallel of how do we do it outside the hospital? How do we do it with the person truly at the center of care?
Great, thank you. Switching gears a little bit, keeping the supplier in mind. Todd, I'm going to come to you on this one. You know, we've painted this picture of the virtual care setting, the supply chain of the future. How does this new virtual fragmented care setting change the expectations of suppliers, in particular the expectations by GPOs and IDNs?
Sure. Thank you for the question. The nature of the relationship with the supply base, and I would say that this follows very similar or very closely with the evolution of supply chain and organizational efficiency that David mentioned at the outset. The nature of that relationship between a supplier and a provider is going to change dramatically. You know, historically, you know, when I come from the corporate world, historically it was a very transactional focused relationship. And if the product showed up on time and I got your invoices and paid you on time, everyone was happy, everyone walked away. Ultimately, what we're talking about when we start focusing on the consumer centricity and really starting to push the continuum of care out to the patients, where they are, where they reside, in their zip codes, it becomes much more important that we have aligned incentives and that we've got an aligned vision as to what the goal of that patient care is. And it's a better clinical outcome than what they could get otherwise if we were not aligned. And so what that requires then is a different conversation with the suppliers. And it's not just with a single supplier, it's multiple suppliers across the supply chain, and it may even be, for the suppliers in the room, it may even be your suppliers. There is an entire value chain that has to be aligned to that incentive in order to drive the best outcome for our patients, wherever they are. And that's going to require flexibility. I heard that. And the pace of change, by the way, we all feel it in this room. The pace of change in our world is staggering. There's an institute that does some research, the Future Today Institute. They every year come out with an annual report. The 2018 report's coming out in a few weeks. In 2016, there were 80 trends that they were tracking that impacted multiple different industries. Last year was 165. And what they commented on is those trends are growing exponentially because there is a convergence. There's telecommunication networks that are now able to reach out and connect the most rural parts of our country and around the world, frankly. And then there's also capabilities that we can deliver to them through platforms like an iPhone or an iPad or any number of devices to interact with them in a much more consumer-centric way. And so it's really important that as a supply chain, we recognize that there's a data flow through that supply chain. It's multiple ends or multiple steps along that value chain, and we have to have access to all that information. We've got increased transparency throughout that. And we also need to align ourselves to that vision of ultimately providing the best care for our patients that we can. And I think everyone in this room, when we think about a personal story that we've got with a patient, with a family member, we know why we're here. And yes, the day-to-day distractions come along, but if you keep that at the forefront, ultimately we can deliver the right outcome.
Great, thank you. Nita, I'd pose the same question to you, if you would, please. What do how are your expectations of suppliers changing, and also when are you getting them involved? Earlier, later, the same? Any thoughts?
So I'm really glad that you asked Todd that question first, because it gave me some time to think about it, actually. And I was kind of using what Randy said and what Todd said, what you said. So you talked about consumer-centric, and you talked about fragmented care, and you talked about bringing care to the consumer. Well, I think that that's why Amazon is having some success, right? It's incredibly successful. It's convenient. So I will give you a personal story. My mother had a hip replacement about 5 weeks ago, and she's doing exceptionally well. And one of the things she can't do is bend over, but she wanted to be able to put her socks on. Well, there's a supply that you can get that helps you put your socks on. And her occupational therapist brought her one, but she didn't have one to give her. So guess where we found one, right? On Amazon. And it's not expensive, but it came 2 days later. Now, imagine if you had a hip replacement in a hospital and the hospital anticipated all the needs that you had. And we worked with our suppliers to provide the items that the patient needed before they had to go on Amazon and find that item. So I think that it's very important to involve the supplier early. It's very important to anticipate what the patient needs at home and what's going to make their lives easier. If my mother did bend over, she had a higher likelihood of dislocating that hip. So although that seems like a little thing, a sock aid, it can potentially be something that prevents a readmission.
And I was just going to add to Nita's comment, that requires, right, in order to be that predictive, that requires information flow, right, and awareness up and down the supply chain in order to make sure you meet that demand before it even occurs, right? And that's coming. We're not there yet, obviously, clearly. But that is the convergence of technologies and processes and partnerships. Ultimately, we will get there.
If I could add.
Please, Randy.
I think the more we think about value and put yourselves as consumers at the same time, like you just brought up the hip, a lot of what we do in virtual, most of what we do in virtual right now is inside of our hospital. And what a lot of us don't think about is the hospital is optimally staffed 35% of the time. I kind of have a teasing thing, but not so much so really, of saying if you're going to have a cardiac arrest in the hospital or an ICU, try to do it Monday through Friday from 8 to 5.
Timing's everything.
It's the best time to do it. But if you think about it, we've optimized around providers, around procedures, around things that, all right, we gave the great hip replacement, but we didn't think about the quality, ultimate quality of life, which is where it's going, and it's going to add value and differentiate value, whether it's in the hospital or extending outside. And that is big data, it's analytics, but it's supplies just in time, tied back to the health of a population.
Can I add one quick thing?
Please,
too,
David.
John, back to your question about kind of what is all this going to mean for the relationships between GPOs and suppliers and buyers, and all this is important. I go back a little bit to what I said earlier about speed. Whether you're talking about doing things better in a hospital setting, shifting to other kind of less expensive, effective settings for care, and the impact of that on products and services from suppliers, we're going to have to be able to respond quickly, and it's really hard to respond quickly to opportunities, whether you're on offense or defense, if you don't trust each other, right? It's incredibly important to be able to short circuit some of the stuff that may take us weeks or months to do. If there's an element of trust between the parties, you can generally, not always, but go faster. So we got to stop doing things with each other that disrupt trust. We got to do some things to build on trust. We got to agree on data sources that we're going to together sit down and look at, that we fully understand. We'll get rid of smoke and mirrors, and we'll actually develop a relationship that helps us be agile and fast. Without that, it's really hard to respond to things in a timely way. By the time you do, either something else has emerged or somebody's already figured out a way to do it, and sometimes it's important to, plus we just get to value quicker, right? If we can move fast, and that's hard to do if you don't have a collaborative, trusting kind of relationship anywhere in the whole value chain.
Interesting. Just a couple of comments. It was interesting to get the email from Modern Healthcare this morning. They covered yesterday, Secretary Azar's presentation yesterday, talking about value-based everything. And while that was interesting to see, I think we've all been working on that, talking about it for a couple years. But Nita touched on something that I think's really at the core of the Amazon scare, threat, whatever you want to call it, and it's convenience. In the middle of February, I read an article in the New York Times by a Columbia law professor called The Tyranny of Convenience. Has anybody read that? Did anybody read that? I highly suggest you look it up. And this is just a comment, and if anybody wants to jump in, you're more than welcome to. But it's getting that, he's kind of getting to the point where convenience is now a component in the value equation. You know, your quality, service, price will always get you the market share you deserve. But now the price that's paid takes into consideration convenience. As you know, as you define that maybe differently, but to your exact point, going to Amazon to get that instead.
Along those, I live in one of the markets that I can get a lot of stuff same day or in 2 hours. And I'm getting reminders all the time of what I might need. Back to what I was saying about the ICU, when we introduced virtual, integrated, partnering, trusting relationship with the bedside, where we're at right now inside of our system is, I make it simple, about 130,000 bed days won't occur this year that we're supposed to. 130,000. And about 1,200 to 1,400 people will go home who are predicted to die. And what we did is said we should have 24/7 convenience, if you will. You should have the same level of care there, and it doesn't matter if you're in our 1,000-bed teaching hospital or if you're in our 40-bed critical access hospital. Now, we won't get there to perfection ever, we won't get there overnight. But again, when we start thinking about convenience or value or what's expected, the world changes really quickly. We've been a fee-for-service driven healthcare system or sickness care system for decades. And most of us have been rewarded when the system has fragmentation. Yeah. Worse outcomes mean more money in the system. So as I look at it, the Amazon, JP Morgan, even in a different way, it's not about Amazon and what they're going to do. It's about a market that's frustrated. You know, it's Warren's words saying the tapeworm that's continuing to eat at our economy. And it really is. And so I think we, as opposed to doing the incremental fixes, we've got to do sustaining innovation, but we really need to rethink what should we be delivering.
Yeah. You know, the interesting thing to add to that, though, is when we think about, I like using the word consumer more than patient. That was an epiphany for me in this conversation. We use the term patient, but really, they're a person, a consumer, and shouldn't be a patient, shouldn't be in that hospital to start with. And having said that, though, our supply chain isn't connected to that consumer across all the stakeholders. For that data to get transparent, we have to connect the data sources from the EMR to the raw material supplier for all that we talk about to become possible. Realistically, as we try to do any innovation or change, when you said, how do you make change happen? The easiest way to make change happen is to show people the data. Let it become empirical to them. Let it become something they can touch and feel, be it tying the product to the outcomes, to the consumer, to the setting. And in doing that, none of our systems or automation is set up to exchange that information. Today, all our systems are set up to keep that information hidden from each other. My data is mine, the patient record is protected, your raw materials can't be seen, there's a problem in Puerto Rico, I can't tell where the product lives in the country. None of our supply data sources or even consumer data sources were ever set up to create this end-to-end seamless consumer-driven supply chain. So if we're truly trying to get to that world, we have to connect our data sources to get there.
Yeah, interesting take. One of the top questions I get asked by suppliers all the time is, our IDN customers, certainly the GPOs, are all driving to this era of cost, quality, and outcomes. And when a supplier will ask, when am I going to get paid for increasing the other two as opposed to just decreasing the cost? And one of the real encouraging parts of this convenience article was the example of Napster, which was free. You could go and download all the free music you want. It became illegal. I guess that's sort of an issue. But nonetheless, it was completely taken out by iTunes because iTunes was so much more convenient. I know I've never had a bigger music collection. You hear something, boom, it's $1. It's downloaded. Unfortunately, my 4 kids know how to do it too, so they're constantly downloading. But I think that's real encouraging for suppliers to think about when we have whatever it is, 70 million, 100 million Amazon Prime members that want that convenience, and these millennials are now 37 years old, so suppliers, distributors that are able to do that, I think, can get rewarded. So I've had one question aimed at least to each panelist so far, so we're kind of going to the second round of questions here. So I'll steer the questions, but anybody else who's interested in that topic, please jump in. And Mr. Hargraves, I'm going to come back to you if I could. And keeping in mind, again, the suppliers, when you look at innovation in this new supply chain, and in particular, the role suppliers have traditionally contributed to that, when and how will suppliers be involved in innovation in the future, and how will that contrast to the past?
Okay, I appreciate it. The parting comment on your last one of convenience, I don't want to reopen it, is think about one of the things you said about your kids in the iTunes. So one thing to watch for is, when does convenience lead to overconsumption?
Yeah.
And it's just note to be said, right? So then you wind up in these cycles, but we'll put that to the side. So an interesting thing, though, if you take a look at that supply chain of the future and supplier and innovation, if you go, and I'm going to say with Cymryd, your conversation that you had about how you went to the CSC and then you pulled back to your core, one of the things that I've seen happen again in other industries is when you pull back to your core and you let some other folks who are experts do it, the reliance on suppliers becomes greater. Right? So suppliers, where you're trying to innovate, a fundamental change that I can't wait to happen here is that move from all suppliers are arm's length, all suppliers are to be trusted only so far, right? But in other industries you've seen, you say, no, listen, I can't innovate, I can't produce a new product without suppliers. And therefore, there's concepts, new product introduction and early development teams where you bring the suppliers, not all of them, but a handful of your most trusted and most critical, and you bring them in, they're actually part of your process development and your product development. It really doesn't exist for today, but I can guarantee you that Dell doesn't ever produce a computer without having design sessions with Intel, because they already know what's going to go inside of it, right? So I think we're going to get to that stage, but we'll do a flip and we'll realize that some of the suppliers truly are partners and can really help to innovate and change it. And suppliers at the other end do risk being, because I'm not going to make light of that consumerization, risk being marginalized and commoditized and shopped regularly if they don't have that ability to add that value and truly drive the change. So I think you'll wind up with some level of bifurcation between the two. Just another comment, since I have a captive audience here. Really, really big suppliers in any industry don't typically innovate. Okay? It's a fact. Look at phones when there was a phone monopoly. Look at airline prices when they were regulated. Really big companies then that are also, when you had regulation, don't typically innovate. Small ones do. So I want to just explain to my peers of the GPO thing, we need to have a commitment to the small suppliers, the diversity suppliers, the emerging suppliers, in our quest to have the best cost on the product. We can't turn our backs on all the small companies, because that's typically where innovation comes from.
Will you please expound on that? Why is that good business not just the right thing to do, to use local suppliers, diverse suppliers?
Well, it's interesting. So on local suppliers in particular, they also happen to be patients of the population that you're in charge of, right? So there's that. And as it was in an article just recently, it said 60% of the health, I'll get it slightly wrong, was determined by your zip code and 30% by your genetic code. You might have seen that article. So if you have a strong economy within your population that you're in charge of health for, you will have a healthier population. So there's that.
1 out of 2 isn't bad, right?
Yep. Yeah. And so the second portion is large companies and public companies, as they go through it, have the need to constantly drive that growth and earnings. And so it's typically, you say you can't cut your way to growth, but you wind up with a narrower and narrower funnel, right? I can't dedicate more than 3% to R&D, and they simply can't take the bold risks that some smaller suppliers can. And so that's why we absolutely believe, and it's core to us, you need to continue to do both and offer that choice.
Anybody else want to comment on that? Yes, please, Randy.
I think related is a whole question of value and what we're willing to pay for something, because so much of what we've done in this is, we squeeze, we get, how do you get another nickel out of it? I'll give you another story of 25 years ago. I was developing a program for AIDS patients when we didn't have much else we could do. Presented to a doctor who was a specialist, a classic AIDS presentation of somebody who was going to have pneumocystis pneumonia, which was going to be a $40,000 hospitalization in about 3 or 4 days. And asked him, I said, could you take care of that patient today on a Friday afternoon and keep them from getting in the hospital? And he said, absolutely not. It just, there's no way I can do that. And I said, I thought you could if you, he said, it would be 3 to 4 hours. It's Friday afternoon. My practice would fold overnight. And I said, so, Sam, could you do it for me for $10,000? He said, when do I start? Now, $10,000 would avoid a $40,000 hospitalization on Sunday. That's actually good business if I have risk. Same thing when I was chief medical officer at Caremark and we did home infusion and saying, could we have a nurse infusing antibiotics anywhere within 2 hours in a hotel room? And the answer at first was absolutely not, we couldn't. But yeah, we actually could. It was a different price point. And it delivered a very different value in the setting of somebody who needed that. So another thing we need to think about in terms of not just convenience, but value chain and getting outside of fee-for-service is there may, and many people are starting to look at this, what's the value you can bring to what the supplies and things that you bring to the table? Because there's a lot of logistics that people are going to put value on, especially as they move into risk.
I wanted to respond to something David said about when you want to innovate with a supplier, you truly have to let them in. And you have to make them part of your core operations. So I wanted to share an example. So tied to the CSC example that we outsourced, I completely agree with you. We decided to exit the CSC business, the consolidated the service center business, and we outsourced it to Cardinal Health. And the first thing that I told my supply leader, my materials management leader, was, if they fail, you fail. You've not outsourced anything, you still manage this business. You have to sit in there and your job is to make them successful. They don't understand the culture, they don't understand our politics, they absolutely do not understand our day-to-day operations. The idea of outsourcing anything to a vendor does not take away the responsibility of a supply chain to operationalize. Secondarily, as a partner, you should be empowered to speak up and be part of the operation. So my message to the supplier was, do not appease me. Do not appease me. If you have something difficult to say to me, you are empowered to speak up. And that, I think that is a different relationship to happen. I just pick on one. But when you innovate with someone, you have to empower the supplier. They cannot be an appeasing salesperson that is there to make sure you're happy, because sometimes what I'm asking for is absolutely the wrong thing. And I may not know any better. And I think that's where supply chain leaders have to open the door to the supplier community, that you look externally. You see 5,000 hospitals. If I have the wrong idea, speak up. And you're empowered to speak up, but those relationships have to be created by providers. It has to be a two-way dialogue in which there's empowerment on both sides.
That's pretty powerful. The ability to build trust enables so many things. I was sitting in the purchase services seminar earlier today, and risk share came up. And David, I think you commented. I put that on LinkedIn a couple years ago. Does anybody have any real examples of going at risk, sharing risk? And time again, it comes back to trust. What data do we measure off of to share the risk? And it's always an interesting conversation. I'd like to shift gears a little bit to resource implications to this constant change and ask our IDN panelists, and please jump in, and if you don't have such nerve, I'll certainly assign it, but how does a more consumer-centric environment impact your supply chain strategy and operation? Is it more people, more facilities, more contracts? What do you see changing as your supply chain, similar to your point, extends all the way back to the patient, to the consumer, as that person merges into one? Anyone who'd like to take that, please.
then, we were having this conversation about the chicken and egg of investments required in infrastructure to enable a new supply chain. So we talked about large health systems like the Cleveland Clinic that can put in the automation that's required to make a new supply chain work. So we've spent millions and millions of dollars to make a world possible in which we automated our inventory systems, connected them to the EMR. We're taking data standards, embedding them. We're rebuilding and reconfiguring how outcomes data and product data interrelate, so we can pick up and compare products and their outcomes to patients, to providers, and then link it back to the patient. We can talk about, for this patient encounter, would a different care setting have made more sense? I worry about the smaller hospitals that do not have the ability to create that automation, that cannot connect those data sources. And then the skill sets required in the people that work there are different. Instead of having automated data sources to collaborate with suppliers on, those people are mining data sheets. They're having to look at this data with zero help. And interestingly, they're paying the most for the product. And we were having this conversation offline. It's that rural hospital that probably pays the most for the product, that absolutely cannot measure outcomes tied to that patient, that doesn't have a supply chain leader that is educated on category management or channel optimization or end-to-end supply chain optimization. So this idea of how this changes systematically overall worries me, because I see the larger IDNs probably putting in the infrastructure investments that are required, bringing in the right skill sets, creating the right partnerships. The GPOs, the distributors, the Amazons, guess who they all approach for that innovation, that partnership? Guess where the automation goes in? Interestingly, as we scale this to the larger health system equation, I think that's where the challenge comes in. How do you scale the solution to everybody? And how does that become possible for that larger market?
Well, I'll make a comment on that.
Please.
One of the other things we had talked about kind of in this offside bar conversation was also the role of other business partners, whether it be the GPOs or the suppliers, in enabling the education as well as the infrastructure and data to support these things. So I think that's a real collective opportunity for us, is to be sure we're enabling providers, not just the big Cleveland Clinic and bigger organizations, but some of these smaller organizations as we transition to more of that outpatient care, because either the smaller hospitals are going to need it, they're going to need our data, they're going to need us to enable their efficiencies and processes. But as we move from more of a patient-centric or to a patient-centric world, the patients are going to need it, the consumer's going to need it. So we worry about these smaller hospitals having resources. Well, the secretary was up there talking about, patients are going to have their own healthcare records. They're going to be making decisions that are different than we've ever had them decide on before, too. Imagine being the parent who has to decide whether or not this test should be given or not. And we empower them with information, we have to empower them with knowledge. So I see that as a big role of GPOs, of suppliers, to enable some of those smaller organizations, as Cymryd was alluding to, but also even the consumers as we move to a more consumer-minded supply chain.
Well, John, my 27-year-old now daughter, when she was 25, 2 years ago, had a baby. She's having another one in May, so grandfather of two soon. But being a child of somebody who's been in healthcare his whole career, I don't know if it's a blessing or a curse, because she contacted the hospital through her physician's office and wanted to know, okay, I'm going to be there kind of one night. I want to know everything you're going to do to me. I want to know every drug you're likely to suggest I need to take. If you're going to have to use any kind of supplies on me, I want to know what they are. She didn't ask what they cost, but she spent hours doing research from her computer on every drug, everything that could go wrong, every instrument that would be used if suddenly they had to do a C-section, all that stuff. And all her friends do the same thing.
No.
And so we got to make it easier for this consumer, millennials, whatever. I mean, they're now almost 40 years old, the leading edge, right? So they are not only going to be moving more and more into the patient populations in different settings, but they're also the people that are the supply chain professionals moving into our ranks and moving into leadership roles in our health systems. They question everything. They want to know about everything. They have tremendous power, but we don't always make it easy for them to get answers to the questions about why this drug that I hear costs twice as much as this drug. Why this thing they want to put in my husband's knee, he blew out, versus these? So we got to start translating information and content in ways that lots of different people, not the physicians, not the supply chain folks, not the purchasers, can understand. And I don't mean the commercials on TV.
Yeah.
I mean useful information that they trust.
Yep.
And we got to figure out a way to do that.
And where they are, right?
Yeah.
The day is gone when you go to the car dealership to get the information about the car.
Yeah, my kids would think, are you kidding?
Yeah.
Are you kidding?
What? Trust that guy, right?
They've done it all.
About
They've been researching it a month before they ever set foot on a car lot.
That's right.
So.
And David, you mentioned a great point with providing that information to the consumer in a way in which is meaningful to them. But we also need to think, and we've talked a lot about the consumer, we also need to think about when we talk about care for that patient, it's really the family. There are relationships that are impacted by that care, and Intermountain Healthcare, which is a parent company for Intelair, is building out that type of capability to work with those that surround the patient to make sure that, and in many cases, they are the caregivers. When we talk about home care, yes, we may have virtual care, but we also have people in the room that are family members, and today we probably don't provide them with the level of information in a consumable way that really empowers them to do the right thing. And so, yes, we have to share that information. We have to make it very easy for them to understand. We also need to consider the relationships that patient has, that consumer has, and how we can leverage them as well.
Thank you. Nita, I'm going to ask you the same question Cymryd answered, was how do you see things changing in this consumer-centric environment? What will you advise your supply chain to do different to meet that consumer-minded patient, where they're going to be if they're not there already? Anything come to mind?
Well, so I work primarily with the supply chain in the hospital, and it's actually pretty good, right? I mean, we have to deal with shortages, and but if we want to get something within a couple of hours, we can get our distributor to bring it in on the next truck, almost always, right? So the issue is less in the hospital and more outside of those four walls. And I don't see anyone that's doing that. I don't see anyone that's moving the supply chain outside of the four walls to, they do to the clinics, right? I mean, that's also, I consider that kind of still within the walls, but not really to the patient's home, right? So the question is, like, let's say when my mother needed that sock thing, somebody had called her in the morning from the hospital and said, how's everything going? How are you feeling? And is there anything that you need, do you think, in terms of supplies? And she said, I need that sock thing, right? I mean, literally, one of the reasons she got it is because I was there. I went online and found it. I think that would be a great integration of the supply chain, right? I have to tell you, I was listening to the innovation question. I started in medicine. I graduated from medical school in 1985. I think you suppliers are amazing. The developments that I have seen over the past 30 years, pulse oximetry, end-tidal CO2 monitoring, anticoagulants, we have a cure, an oral cure for hepatitis C, which has essentially no side effects. So I think our suppliers do a really good job, and I thank you for that. But healthcare is changing. It's moving outside of the hospital. It's moving into the patient's home, as you know, as you've told us. So the supply chain needs to move there also, and we haven't done it either. And I'm not sure how to do it.
Thank you. Reddy, did you have a comment?
Just building on that, is if you think about the hospital in a different way, I'll go back to my old economics class, it's in a way, the hospital's a market maker. It's created an environment, a campus that brings teams together, resources, all the logistics in order to provide an episode of care. The care has become a surrogate marker for outcome. Outcome is going to become more important. What's my quality of life? The majority of as we built these huge campuses, then we figure out how to feed the beast. And that's just how most of us grew up and did everything. But that's the disruption that's occurring. And so one of the things I challenge us also is to think about much broader, longer-term partnerships. And as opposed to looking at somebody as a competitor, are they a potential partner, a collaborator? When some of the early health systems got into full risk, if the system across the street that used to be their fierce competitor could do bypass surgery at half the cost and a better outcome, when I'm actually writing the check, I go to my CV surgery group and say, guys, can you get a little closer here? In fact, a lot closer, because otherwise that makes a lot more sense. When your product is an outcome and taking care of the consumer, the employer, et cetera. So it can mean that if we don't have everything set up to do get to the consumers within a couple hours, is it working with a CVS, Walgreens? Is it working with an Amazon? They can't do a lot of things that we do really well and will remain really essential, which is taking care of the really, really sick people. But we can't stop at just the sick people in our campuses. We've got to get into this other model. So who has the value proposition? Or if you're going to do it yourself, can I honestly say that I'm going to beat CVS's 11,000 stores and access within 10 minutes?
Sure, so I'm sorry, go ahead.
No, go
I was going to add to what Nita said. What are supply chain people in hospitals thinking about, right? So an early germination of a thought that we're doing at the clinic, it isn't completely thought through. I'm sharing early thoughts with you. We're taking what we're calling a concept called channel transformation. You take a patient and the different settings of care that they can receive. Home health, physician offices, our ASCs, our ambulatory surgical centers, our family health centers, our hospitals, we're classifying them into different channels. So specifically, what is going to be serviced out of a prime distribution model in a GIT? Secondarily, if you're in home health, what is that formulary for home health? What goes into a checklist and who is going to distribute it? 3, if you're going home with your family, are you going to get a list of products and who is your fulfillment partner for that particular list of products? If you're looking at physician offices, is that the core competence of any distributor today? And if it's not, can it go to an online retailer? Are there different ways to do this? But what we're finding is we need to iterate on different concepts. One size doesn't fit all. We may have to almost stratify the channels for these different types of settings. So specifically today, what are we doing to get ready for this? We have not been able to find one partner. What we are doing is finding different partners for each of those settings. But what do we need to provide that partner? We need to provide that partner with a list of products that they need to be able to carry and the types of locations they need to distribute that product to. Supply chain doesn't seem to have the list of products ready today. So one of the main things is the hospital couldn't give that online retailer list of the products that that patient might need when they go home. So I keep saying this is a two-way street. The hospital and the providers have to get the savvy to get their data ready, and then the partners that they pick have to have the commitment to serve that market being a home setting, a ambulatory surgical center, a physician's office, a hospital. We've traditionally thought of this as one customer. It's not. I think we're beginning to understand we only ever thought about the hospital, that large building that things were delivered to. Nita's absolutely right. It's not one customer. There are about 6 different settings that can't all be serviced out of a distributor or a CSC.
David, did you have a comment?
Well, I was just going to say, I think I've heard the word Amazon 9 times. I actually thought by now it'd be about 40, but for all the talk and the interest by kind of the established players in supply chain circles, of them being the disruptor, I think part of what we're getting at here is if we can find partners that we trust, we want to be disrupting every day. We talk at our senior team meetings every Monday. How can we disrupt? Because if you look at what we got to do in terms of the gap between how we perform from a value and quality and cost perspective and patient experience to where we ought to be able to be, when you look at the way a lot of other people around the world do some things, it's a big gap. It's not just a little change we're looking for. So we got to disrupt. Frankly, we're not really interested in waiting around until somebody like Amazon or Walmart disrupts. We're looking for relationships we can build where we've got trust, we've got the ability to move fast, we got the ability to share information in a trusty way where we can disrupt and enhance and optimize every day, every week. And I think going back to some things that Dr. Moore said, we've got to find a way to establish some longer term kind of partnerships built on trust, built on kind of a mutual set of objectives, so that as soon as something that's coming out of that collaboration seems very self-serving to one of the parties but not focused on the end game, then we're going to back away from that, right? And that's what you see. Everybody wants to collaborate. Nobody's against it.
Yeah.
It's hard to do.
Yeah.
And it's hard to have the right circumstances to do it. So we're looking to do that, whether it's suppliers, our members across the country, in ways that lead to the kind of innovation that we so desperately need.
But are the suppliers, my question to the suppliers out there, and I don't expect an answer, is are you also fragmented? So is the sales rep that's calling on the hospital different than the person calling on the physician's office, different than the person selling to the home care market, different than the person who's selling to the online retail market? And across all those channels, have you ever shared that data to understand how you service that patient? And has that model changed in your industry? Or are you beginning to understand how 6 of your products reach that patient through 6 different markets, but all tied to a very similar disease state? And it's the same challenge that we have, that you have. Our market is shifting, it's becoming consumer-centric. And your market is also changing because you've sold that product differently across those channels.
It's interesting you say that. Oftentimes when I talk to supply chain leaders and I ask them, what advice would you give suppliers? Usually a multi-divisional, large national corporation comes to mind, and the answer is, I want one contact. That's very common, and I'd like to just change the conversation a titch back to our GPO panelists about suppliers. You guys are always gracious when I ask you to help participate in something with the Association of National Accounts Executives. You guys don't take it lightly how national accounts executives need to be elevated, bring better value propositions to our nation's hospitals and health systems, and it doesn't go unnoticed. But when you look at resource allocation for these suppliers in the audience, there's been so much work done about the supply chain leader of the future and the different skills they need. If you go to ARM's website, there's lots of videos, very detailed on what's being different about the health system and hospital buyer. They're getting better every day. Put that same lens, if you would, on the suppliers. What skills do we need differently? What should they be working on to be successful in the future that lines up with all the things we've talked about today of being a better supplier for our nation's hospitals?
Can I mention one little sliver?
Please.
One little thing, because it's a big deal to us at HealthTrust, and that is this whole, and it's been around for a while now, but it's only going to get worse, and that's cybersecurity. What we find when we interact with some of the supply community, national account execs, whoever, I wouldn't call it an unwillingness to really kind of talk about what we need from them, but in some cases it's not really understanding the nature of the threat, the nature of the vulnerability with your product, your device, your technology, your pill, and connect us to the people that can have a conversation, because it's only going to get worse. More bad players, more sophisticated bad players, more stuff that we all produce that's going to be digitally connected. That is a huge area of focus and concern for us on behalf of our members, and we need the suppliers to do what we need to do and get to a common understanding of the problem. Let us do some assessment and scoring so that we can have conversations about what we need differently, but we often find the folks we're interacting with don't fully embrace the real severity of the problem and don't understand some of the things that, and we're trying to do this in a way that's not overly cumbersome or threatening or inefficient, but we are asking for some stuff related to that because it's a big, big deal.
It was one of my 5 predictions for 2018 that it will be a major cybersecurity breach and a supplier will be blamed for it. And correct me if I'm wrong, but it's not necessarily just suppliers that are on your hospital's networks, right, or part and parcel to the patient care. It could be something from someone internally sending an email from that company's email address saying, can I have access to this? Phishing for security to things they shouldn't have, that could upset the whole.
They are unbelievably creative at ways to get in.
And they're targeting people, right? Not necessarily systems, so.
Specific populations of people they think are more vulnerable.
Add to that, and it is, David's right, it is a huge, huge concern. In my career, 20 years in supply chain, I started off at IBM, but in my career, cybersecurity, the issues have just escalated exponentially. And it was several years ago that Target had a breach, and that was a big deal at the time. And since.
Oh yeah.
But Target's breach was because the HVAC supplier that was on site had an issue. And if you think about, do you think Target actually evaluated that HVAC supplier, that local firm, to see if they were really buttoned up as it relates to security? I doubt it. But that's where we are now, and that's just the nature of the environment that we operate within. As I mentioned, one of the things that's going to happen is we're going to have information flows up and down the value chain, multiple layers. And if you as suppliers aren't asking your supply chain whether they're hardened, that's a key concern for me as well. And so if we're going to truly be able to share and trust each other and share that information up and down the value chain, we have to make sure that those are hardened. Now, any system is capable of being hacked. That's true. You mentioned, in 2018, your prediction, and I looked at my watch saying, did that just happen? I'm sure somewhere that has happened just today. But, if it's not just systems as well, it's processes, it's culture, it's understanding of the threat. A hacker can take a USB key and throw it on the ground in front of your facility, your campus. That will get picked up. It will get plugged into one of your systems on your network. It will be a virus now in your system. And if you don't have people that are trained and understand that that's a concern, it's going to cause tremendous problems up and down the supply chain. And you want to talk about distrust and concern? That's something that we've got to work through as partners. To make sure we all understand what the threat is and also are hardening our systems and our processes and make sure our people are aware of what the challenges are.
I appreciate you bringing up cybersecurity. It was certainly on the list. I'm going to do one sanity check and then come to you, David. If we have any questions and you want to run them up, now's probably a good time. And if you'd put them in order, that would be great. David, did you have a comment?
I will. Fully agree with everything on cybersecurity, but again, captive audience, I'll give a couple other kind of messages to the suppliers, if you will, in no particular order. One, recognize that the pricing transparency, my request of you is get your pricing discipline in order.
Thank you, Steve.
Get control of your reps, get control of your organization, have a defensible pricing policy, whatever it is, but have it defensible. Because it's now down to hours or days by the time a price is in the market and that everybody up here knows about it. So you just have to, as all that data has flown, you just have to know that and be aware of it, control it. Second, understand that your behaviors as you set those pricing policies is a contributing factor to the consolidation both on providers and suppliers, right? So as you disadvantage smaller facilities in order to give the discounts to the larger ones, that makes those facilities less able to be economically viable, and they just get bought, and now your bigger customer is bigger still. So you have to understand that there's a cause and effect in there as part of it. So get your pricing in order, think about the impact that it has on you as you go forth. I've got about 72 more, but in the interest of time, I'll just stop with those two.
And I would want to add to that, so that the pricing discipline, we talked about patients as customers, as consumers in a continuum of care in a variety of different settings. Cymryd covered that very well. And frankly, in my mind, it's to have different classes of trade and a different pricing model for each class of trade for the same product. That's a huge concern for me.
I agree.
You're disadvantaging particular market segments, and it becomes very difficult for us to, especially if you talk about a large system or trying to compare pricing across systems in different settings, to understand why this patient, Bob is in the home care setting, but now he goes to an IDN and the cost structure is completely different, and Bob gets charged a different thing. That's a key concern for us as well.
I'll add one more thing. So we need innovation and we need the pricing discipline, but we also need to think bigger, right? So we can't be just thinking about pricing and transparency. We have to be thinking about the consumer, the patient, the outcomes, and transparency. So innovation, not just with products, but how we can work and partner together with providers or with data sets so that we can really forward care and reducing the total cost of care, whether that be outcomes related or maybe more logistics oriented in terms of demand planning. But we really have to move beyond transparency from just a price consideration to that outcomes and that flow of product through the entire supply chain so that we can collectively have a win-win in terms of outcomes, both from our own business perspectives, but also really from the provider perspective and more importantly, the consumer or patient's perspective.
That's so important because I was going to just give the counterpoint again is if I go to a grocery store and they're charging $3 for a can of Coke, I go nuts. But if I go in a restaurant, it's expected. But back to value is Supplying inside of a major hospital has all kinds of economies of scale, easy. Pricing, the pricing consistency works as long as there's only kind of a fully defined characteristic of how that product is going to be delivered. When that product is actually driving a different outcome and you're putting different support systems, which all have costs with them around it, when we get into value-based outcome delivery, I think pricing is going to be, you need transparency, but it's going to be much more necessarily complicated.
Agreed, but if you try to do risk-based contracting without first getting to value-based data transparency, we are all in trouble. So this is my head dialogue. I see too many suppliers approaching providers saying, I'm going to do a risk-based contract with you. Value-based purchasing, and my first question to you is, what are the KPIs? How do we measure this risk? So when that first negative outcome measure comes up, who measures it and how? And how is that attributed and who pays what? I've done 3 of these pilots, and I've realized that we are not 100% ready to measure those outcomes. And yet, every day, a new supplier approaches a large IDN saying, let's do a risk-based contract. So it's absolutely the right way to go. My caution is, let's do all this hard work first. It's not an instant solution.
And together. It's going to be longer-term relationships working on it together, or we're not going to have it right up front. The good news is there's so much potential value to be tapped. Collaboration, getting in longer-term relationships, and more of a Walmart approach where when I was in business school, a lot of the executives that were my classmates had Walmart as their client. And they said they were the toughest and they were the best because they're going to squeeze the value over time, but they want you to be profitable and survive. In contrast to a Sears and Roebuck who said, I'll chew you up and spit you out because somebody else is in line. And who's around today? Mm-hmm. So it's a different form of thinking about how we're going to come together in the future and what we're all going to bring to the table.
John, can I say one?
Please, David.
Just, I don't mean to sound kind of like two sides of my mouth, but while the long-term collaborative relationships are absolutely critical, that doesn't mean that Health Trust and others aren't interested in new entrants into the markets with new products, new supplies, and we do things intentionally to try to reach new ideas from small, maybe 3 people, right, in a garage working on something. But good things have come out of a couple of people in a garage. But if you still got to play kind of by the same rules in terms of demonstrating value, backing it up with evidence, going through the channels in appropriate ways, you got to create relationships, and it may take you a little longer and it may be harder to do. We still have the same expectations that we've been talking about, but that doesn't mean in the search of long-term collaborators with maybe whom we've had a relationship for 5, 8, 10 more years, we're extremely interested in small and diverse suppliers that want to break into the market and are looking constantly for people that have something that's truly innovative, something that's providing a lot more value, that's really different. We're real interested in that.
Yeah.
So.
In fact, providers have preset goals. A certain % of my spend is pre-committed to small and diverse suppliers for me. So that is pretty much the trend. We're community owned, and we believe that, I speak not just for the Cleveland Clinic, a lot of the non-for-profits who are sitting in the room will echo these comments. There are requirements set in our spend categories tied to diverse and local vendors and small vendors.
Quick question for the GPOs. You know, oftentimes we have smaller suppliers in the audience, maybe attending even for the first time. And the age-old challenge of group contracting comes up. How do you guide them or coach them on navigating the problem of having a national contract out there in your members' facilities, but then that same facility, certainly no one on this stage, maybe saying, hey, what's the local deal? How can we get a better deal locally? David, I'd love if you would take that one, because you know, people that are new to it particularly struggle with it.
Clarify 2 things for me if you can.
Sure.
You mentioned about smaller suppliers and how do they crack into the GPO there. But the second one you mentioned...
maybe just newer suppliers that haven't had that conversation, overcome that challenge, or like to your point, have a defensive conversation where they have their rationale for their pricing, or do they give a better local price, even if it's on a local tier?
So a couple of thoughts on this one. One is, I don't know anybody with the Health Trust or Vizient or ourselves that writes 100% compliance contracts. So first know that there's always 10% or 20% or what have you. Even if you found somebody in a sole source situation, you typically have that. And when the small suppliers, they often can't handle much more than that to begin with as they do it. Just other ones have, like we do, our SEEDS program, we have a specific program for small suppliers, and our contracts have language in there that will allocate for that, just to be aware. The bigger problem that I usually see with small suppliers are two. One, they haven't been able to clearly articulate their value proposition. So it's still easier for the supply chain executive to choose the well-known large company that's inside there, because they just don't have the same resources and sophistication and so forth. That's why we have, in our particular case, this supplier development aspect. The second of it is they really have difficulty penetrating the large accounts, because you're talking 60,000, 70,000 employee institutions, and they might have 2 salespeople, right? So those are the two things that come in. I can only speak for our organization. That's why we believe it's incumbent upon us to properly vet that, clinically, financially, and all that one, and then to help those guys where we've got hundreds of people embedded with our member accounts to do it. And I imagine that it's pretty similar. So where they can meet with, I know there's a number of folks here that have the organizations that'll bring their clients on and help those small suppliers navigate. I think it's a really good thing, because you need to understand the ropes as you come through. But I think it's allocated between those, between the allowance on the compliance and then also with the policies and the contract language. And it is possible, but you've got to think through it, know your value proposition, and apply it yourself.
Anybody else want to contribute to that conversation?
The only thing that I would add in addition to that is, as Cymryd indicated, most of us are all really interested in enabling the smaller suppliers, the diverse suppliers, because a lot of the healthcare organizations want that. And so we're very receptive. Oftentimes they offer innovation, and we have an innovative technology process in our organization. Other times it's a smaller business or a woman-owned business. And our hospitals want those programs. They want those kinds of suppliers. And so we're very actively supporting engagement, and again, have people around that will be happy to talk about those programs in more detail with you.
I think that's true for us too. I mean, even in our committed model, there's room for folks to look for things at the local or regional level. I think what's important to us, again, going back to something I said before, is we're willing to and help our members look at the value of something on a local basis where they've got some room within a category to be able to do that. We're still looking for the same things, right? They don't have a track record. And a track record's a positive thing, right? And so when you've been doing something 5, 10 years and proving that your behavior's good, your product's good, competing against that, let's face it, is hard if you're new without a track record. So you kind of got to work extra hard to exhibit the kinds of behaviors, the kind of pricing, flexibility, but most importantly for us, what's the value? How does this help us deliver through our members better care to patients? And if you're new to it, you've just got to work harder to be able to do that. But we want to find those opportunities. We may pilot them at 1 or 2 hospitals. And once we're kind of convinced, then we start taking the conversation to a different level.
Mm-hmm. Yeah, and I'll just add, so my background, I again, started my career at IBM, in very well-known company focused on supplier diversity. One of the things that I was most proud of when I was there was they very much had a process and a framework of supplier development. You talked about how does a new supplier get in the door, and we mentioned Walmart, right? And they're very, very challenging supply chain organization, but they're challenging for a reason. They want the best to come to the fore, and they want those suppliers to develop themselves and innovate and increase their capabilities, and that ultimately what is expected, right? It makes no sense to go engage a small supplier and have them fail, right? That doesn't do anyone any good. Ideally, we've got programs that can bring those suppliers in, help them understand how to navigate a large, complex system, help them get those small wins and build, but also be very clear on the expectations to that supplier. The economic impact of a small, diverse supplier in the communities that our members operate within is huge. It's a force multiplier that those communities need. Those rural hospitals, if we can take small businesses and turn them into medium-sized businesses, that improves the overall economic nature of that community, which, as we talked about earlier, zip code is a larger preponderance of your health care than your genetic code. And so how do we improve over those zip codes? No. It's through programs like this where we talk about small and diverse suppliers where we can truly have an impact.
Thank you. So with that, we find ourselves at a time. We covered a lot of ground today. Thank you so much for participating, everybody. I greatly appreciate it. Thank you for staying, and please join me in thanking our panel.
Yeah, thanks, John. Wonderful job once again. Your involvement with the team has been truly, truly appreciated. Of course, on behalf of everyone in attendance, I'd like to offer our sincere thank you to the speakers, each of you today. Fabulous job. I think we could have gone another half an hour without much problem there. The final person I would like to personally owe a debt of thanks to is Carrie Price, Senior Vice President of Operations for the Federation. Carrie's leadership has been, over this past year, it's been nothing short of just incredible. No one has dedicated more time into making the workshop the very best, so thank you, Carrie. And lastly, we've placed the names, or will place the names, of all those members on our committee, there we go, on the screen. If you have the opportunity to thank any of these men and women who've dedicated quite a bit of time over the last year to make this program successful, please do so. One other little housekeeping item, I just was advised the exhibit hall is still open, so please feel free to visit after this session. And in conclusion, please remember to complete the workshop evaluation survey that you'll receive via link in an email soon after this concludes. It's been another great workshop. We appreciate your continued support of both the Federation and of our Medical Surgical Subcommittee. This will conclude our workshop for 2018. Thank you.